Thank you very much for the kind introduction. It's very embarrassing having a stool even in Thailand. I need one. It's wonderful to be back here in Bangkok, and I've always really enjoyed this meeting. So thanks so much to the organisers for the kind invitation. So I think everyone in this room will know that the major barrier to a cure is the persistence of a pool of latently infected cells. These are long-lived resting CD4 T cells that contain an integrated copy of virus but is silenced while someone is on antiretroviral therapy. There are only probably 1 million infected CD4 T cells that persist in someone on treatment, but it can rapidly reactivate viral replication after stopping ART. So 2 approaches to finding a cure is to, first of all, eliminate all latently infected cells. And this would really be the holy grail, or what we would call eradication. Another approach, which might be more feasible, is to reduce the pool of latently infected cells and enhance immune control of any residual virus. So today I'm going to speak to you about, and this is often referred to as remission. So today I'm going to speak to you about current cases of HIV eradication and remission that we know about in 2026, and then talk about some of the strategies to achieve an HIV cure that are in quite advanced development, primarily immunotherapy, latency reversal, and gene therapy. So what do we know about cases of HIV cure in 2026? Well, first of all, we know that HIV eradication is possible. There are now 9 cases of allogeneic stem cell transplantation in people with HIV where the reservoir has been completely eliminated. Now, in these 9 cases, most of them, but not all, received a transplant from a donor who is homozygous for the delta 32 mutation for CCR5. And that means that the donor doesn't express CCR5, so HIV is unable to enter the transplanted cells. But what's really interesting, in the last few years we've learnt from the Geneva patient that this cure was still possible with a transplant from a donor that was wild type, that did express CCR5. And the next Berlin patient achieved a cure with a donor who was heterozygous for CCR5. So CCR5 homozygosity is not the whole story for cures following transplantation. And in fact, it's probably a combination of graft versus host disease, preconditioning treatment, and the number of susceptible cells. My view is that these cures are more likely in the presence of CCR5 negative cells, but it's not an absolute requirement. We also know that HIV remission is possible, and in something that we call exceptional elite control. So many of you will know about elite controllers. These are rare individuals who are able to control virus to less than 50 copies per mil in the absence of any antiretroviral therapy. On average, this occurs in about less than 1% of people with HIV. But virus is always present. You can find intact viral RNA, you can find intact DNA in these elite controllers. And there are many case reports of elite control over time ultimately leading to failure, and these people requiring antiretroviral therapy. But in the last few years, we've learnt about something called exceptional elite control. This was first described in 3 men from the US in 2012, but subsequent case reports have come from 2 women, one living in San Francisco, Lorraine Willenberg, one living in Argentina, and more recently another male from Spain. In these exceptional elite controllers, there's basically no replication competent virus anywhere to be found, despite sampling very large numbers of cells. And the numbers of cells have varied in these case reports, ranging from millions of CD4 T cells to billions of CD4 T cells, and unable to find virus. Hence the thinking that these rare people may also have achieved a natural cure. What we do know is that in these individuals, there's either no DNA detected, defective or only defective virus is found, or if there is intact virus, it's interestingly in a specific integration site, so it can't reactivate. And this is a new concept where we think about viruses that are integrated in parts of the genome which are called gene deserts, where they're unable to activate. So beyond elite control and exceptional elite control, there are other pathways to HIV remission. The other setting is something called post-ART control. So people that are on antiretroviral therapy for a short period, in the range of 3 to 5 years, and after stopping ART, are able to control virus to undetectable levels. This was first described in a French cohort called the Visconti cohort, subsequently demonstrated in a large US-based cohort, and estimated to occur at a frequency of about 5 to 10%. But more recently, there's been a large meta-analysis of 24 studies with over 380 participants to try and ask the question, how common is post-ART control in adults? And they defined post-ART control as viral load less than 50 copies per mil, 84 days after stopping antiretroviral therapy. And what the study demonstrated was that post-ART control is actually still quite rare. Probably occurs in about 4% of participants. More common if ART is started early, with a frequency of about 6%, and less common if ART is started late, at about 1%. So the true frequency of post-ART control is more in the range of 1 to 6%. And this is really important in cure studies because we know there will be a certain proportion of participants who will be able to control their virus without any extra intervention. And finally, we now know there is a phenomenon called of post-intervention control. Some of the interventions we are now testing in HIV are able to induce HIV remission. And I'm going to focus on these interventions for the rest of my talk. And some of these studies have shown that post-intervention control can be achieved in as many as 20% of participants. So I'll start with immunotherapy, as this is a very large and exploding area of HIV cure science. And this is really focusing on this idea of reduce and control, enhancing immune control of any residual virus. And here's the list of all the different clinical trials that are currently being investigated for immunotherapy to achieve a cure or to achieve remission. I'm going to focus just on these first 5 interventions: broadly neutralising antibodies, immune checkpoint blockade, therapeutic HIV vaccines, TLR agonists and immunomodulatory drugs that have now been used either alone or in combination. So I think everyone in the room will know what a broadly neutralising antibody is, but for those that don't, some people with HIV make very potent antibodies that can neutralise or block a wide range of different viruses. We have the technology to isolate and manufacture those antibodies by cloning B cells, and B cells are the engine room of making antibodies. And you can generate these antibodies as products. There are many broadly neutralising antibodies identified that bind to different parts of the HIV envelope protein. And they're being investigated, as Iskander mentioned, for HIV prevention, Iskander mentioned, for HIV prevention, HIV treatment, and also for HIV cure. So how might antibodies work in HIV cure? They can potentially target and therefore kill an infected cell. But there's also this other phenomenon that we're now observing, that these antibodies can boost someone's own endogenous HIV-specific immunity. So the first 2 trials that showed some success with broadly neutralising antibodies were led by Ole Sogart from Aarhus in Denmark and were published in the last few years in Nature Medicine. Now, both of these studies demonstrated that roughly 20% of participants could achieve ART-free viral control until the primary endpoint of the study, usually 24 weeks, providing they were infected with an antibody-sensitive virus. What was unique about these two studies was that antibodies were given in the presence of viremia. For the first study, which was called eClear, 3-BNC, an antibody given together with a latency reversing agent, romidepsin, the antibody was given at the time of ART initiation, where there was lots of virus around. And in the second study, called Titan, where 2 antibodies were given in the presence of an immune modulator, a TLR9 agonist, they were given at the time of treatment interruption. And this is probably really key to how antibodies can induce remission. One school of thought is that these antibodies are able to form antigen-antibody complexes, and these enhance endogenous immunity, leading to better T cells, but this hasn't been consistently seen, or better autologous antibodies, but this hasn't been extensively investigated. I was recently part of a very interesting modelling study looking at the mechanism of how exogenous antibodies will alter autologous antibodies. And you're going to hear a lot more about this. How can we make someone make better autologous antibodies? And this is what might be happening in these studies where we've seen success. And then earlier this year, we heard of 2 more studies that gave antibodies in the presence of viremia, one called FRESH, which was from South Africa and was done in women, and one called RIO, which was performed in Europe and the UK, and given antibodies at the time of treatment interruption. And both had similar findings of about 20% of participants achieving the primary endpoint of viral control at 24 weeks of follow-up. What about if we put antibodies together with other immunotherapy? Now, this study is a complex combination immunotherapy study recently published in Nature. In this trial, which is a small trial of only 10 participants and non-randomised, a vaccine, broadly neutralising antibodies, and an immune stimulant were given. The vaccine is shown in green. It was a DNA vaccine with an MVA vaccine. The broadly neutralising antibodies were 10-1074 and VRC07, and the TLR9 agonist, lefatolamod. And at the time of giving the second antibody dose, antiretroviral therapy was stopped. So again, antibody in the presence of viremia, and the numbers of participants that were able to control virus in the absence of treatment was determined. And what they found was extremely interesting. So these are the viral kinetic rebound profiles of the 10 participants. And in the top left-hand corner, you can see the standard rebound kinetics in 3 of the participants. Rapid rebound to high levels necessitating starting ART. On the top right-hand corner, you can see one participant who remains aviremic out to 18 months. On the bottom left-hand corner, you can see a slow viral rebound, so clearly the kinetics have been altered. And in the bottom right corner, you can see a number of participants that had low but oscillating levels of virus, allowing 7 of the 10 participants meeting the post-treatment control definition of viral loads less than 400 copies per mil on at least 2/3 of samples for more than 24 weeks. Now, this was often called the kitchen sink study because so much was thrown at these participants, we don't know which component worked. But there was a lot of very interesting immunology done on these participants to see what could predict post-intervention control. And there was a lot of immunology in this paper, but one particular feature that stood out was the ability of the participants' T cells to rapidly proliferate. And this was measured by something called KR67. The participants that had slow viral rebound kinetics are shown here in blue compared to those with rapid viral rebound kinetics in red. And you can see that the participants that could control had a big proliferation of their T cells. And the lead investigator of this study, Rachel Ruttershauser, likes to talk about these T cells like a cat ready to pounce. So if you can educate your T cells to respond very quickly, maybe those people have the best chances of achieving post-intervention control. Now, there are other ways that have been reported that can achieve post-intervention control beyond antibodies. and that includes anti-PD-1. Now, many of the physicians in the room will know anti-PD-1 because it's commonly used for the management of some cancers with extraordinary success. We've been interested in looking at anti-PD-1 and the effects of the reservoir, and in 2 prior studies, my group were able to study changes in the reservoir in people with HIV on ART with cancer who was receiving anti-PD-1 as part of their cancer treatment. So in these studies, we were unable to stop antiretroviral therapy, of course, because these participants all had significant comorbidities such as cancer. We were able to show, though, that anti-PD-1 does actually alter the reservoir, meaning that it increases latency reversal. However, in a recent study of anti-PD-1 called budigalimab, it's a non-licensed anti-PD-1 antibody given to people with HIV at the time of stopping antiretroviral therapy, some success in viral control has been demonstrated. So again, this is a small study. This was randomised, though. On the bottom, you can see 9 participants who received placebo injections at the time of treatment interruption, and you can see the familiar curves of rapid viral rebound. In the upper panel are the participants that received 4 doses of 10 milligrams of budigalimab. That's a total dose of 40 milligrams, which is still much less than the standard licensed dose of anti-PD-1, which is generally 3 milligrams per kilogram. So with 40 milligrams of budigalimab, again, you can see 2 participants in black who had low-level viremia for a prolonged period of time, 3 participants in purple who had altered viral kinetics, and 4 or 5 participants who had rapid viral rebound. So we're very interested in looking at low-dose anti-PD-1 as a step to HIV remission. We're currently in the middle of a dose-finding study for an effective but low dose of anti-PD-1 with the goal of reducing immune-related adverse events. So in cohort A, 6 participants were enrolled at 0.1 milligram per kilogram, 0.3 milligrams per kilogram, and 1 milligram per kilogram. And to remind you, the licensed dose of anti-PD-1 is 3 milligrams per kilogram. So we're looking at a 10th to a 30th of the licensed dose. Once we find the safe dose, the plan is to move on to cohort B, where the anti-PD-1 is given at the time of treatment interruption. So the best pharmacodynamic marker of PD-1 is receptor occupancy. How many molecules of PD-1 are occupied by anti-PD-1? And this shows you the results from cohort A. On the left is CD4, on the right is CD8. The different colours are the different dosing, and I'm showing you results for lymph node and for blood. And you can see here that at 0.3 milligrams per kilogram, you get pretty good receptor occupancy, up to 80% in both lymph node and in blood. And with 1 milligram per kilogram, you get prolonged receptor occupancy, extending out to 17 weeks. So from this first initial trial of 18 participants, we saw no grade 3 immune-related adverse events. We identified a safe dose which gave prolonged receptor occupancy and therefore activity of 1 milligram per kilogram. And we're now proceeding to cohort B, which we're giving nivolumab 1 milligram per kilogram at the time of cessation of antiretroviral therapy. And excitingly, cohort B will be done in both Melbourne and in Singapore. This is the first HIV Cure trial that will be done in Singapore, so we're very excited to bring on another trial site in Asia. It will be led by Barnaby Young at the National Centre for Infectious Diseases. We still need less toxic and less complex immunotherapies. Broadly neutralising antibodies, vaccines, TLR9 agonists, anti-PD-1 are all quite complex. We've been interested in the role of a drug called pomalidomide. Pomalidomide is an immunomodulatory imide oral drug which activates local production of IL-2. It's a relative of thalidomide. Some of you may know it because it's licensed for the treatment of multiple myeloma and also Kaposi's sarcoma, and therefore has been shown to be safe in people with HIV. So we've been investigating pomalidomide in cells from people with HIV on antiretroviral therapy to see what it does to HIV-specific immunity. And we found quite striking results. First of all, the number of tetramer-positive CD8-positive T cells, these are HIV-specific CD8 T cells, dramatically increases when you treat blood ex vivo with pomalidomide. These cells also function better because when we put these cells into a killing assay, so we mix CD8 T cells with CD4 infected target cells and look at how efficient this mix is to eliminating HIV-infected cells. So we measure something called percentage HIV-specific lysis. You can see in orange with pomalidomide compared to grey, which is no drug, you increase significantly HIV-specific killing at all different ratios, 4:1, 2:1, and 1:1. And in addition, you see beneficial effects on natural killer cells. Again, the same assay, mixing natural killer cells with HIV-infected targets, showing you could increase specific killing. So we're in the middle of establishing a clinical trial of pomalidomide called PEACH. Pomalidomide is an immune-enhancing agent for the control of HIV. It will start in 2026. Because this is an oral, well-tolerated drug, we'll be giving repeated 14-day courses of oral pomalidomide with and without cessation of ART. It's being led by Thomas Rasmussen, who's based at Aarhus University in Aarhus, and be enrolling participants in both Aarhus and in Melbourne. What about other strategies beyond immunotherapy? Many of you will have heard for a long time about latency reversal. The goal of latency reversal is to reveal the virus to the immune system. So here's a latently infected cell, and the idea is to convert it to a productively infected cell, now expressing HIV RNA and proteins, and this is done with a latency reversing agent, with the goal to induce immune-mediated killing or virus-induced cytolysis. So there are many latency reversing agents that have been described in vitro. Some of these will be familiar to you, such as histone deacetylase inhibitors, or as I showed you earlier, immune checkpoint blockers. But of this long list, a number have moved on to clinical trials. But in vivo, these agents increase transcription, but the transcription was incomplete, and there was no decline in the number of infected cells. In addition, after the virus is revealed, the cell still needs some help to die. And so some work is being done on drugs which are called pro-apoptotic agents. A drug such as venetoclax could play a role here. But what we do know is that latency reversing agents to date have not been HIV specific and therefore have a range of off-target effects. They're not terribly potent, and therefore we need far more potent LRAs and far less toxic latency reversing agents. So some work that we've recently been doing has been to develop what we call second generation HIV-specific latency reversing agents using mRNA. So many of you will know about mRNA because you would have received an mRNA vaccine, which is essentially a piece of RNA wrapped in a fat bubble called a lipid nanoparticle. And for your COVID vaccine, that mRNA coded for the spike protein. But you can make that mRNA code for any protein you want to deliver. But the challenge when you use mRNA as a therapeutic is that you've got to get it to the right spot. So we recently developed a novel lipid nanoparticle that could effectively deliver mRNA to a resting CD4 T cell. And we delivered 2 HIV-specific latency reversing agents. One was TAT protein, which is an HIV viral protein, and it's specific for HIV because TAT needs to bind to a piece of the HIV RNA to be activated. And the other approach is something called CRISPR activation. It's a variant on CRISPR-Cas9, so we use the same Cas9 protein, but it is inactivated, or what's called dead Cas9. And we use a guide RNA to guide the dead Cas9 to the right spot and therefore make it HIV specific, and hook on something called a transcriptional activator to the dead Cas9 protein. And so this whole machinery can move to the right spot of the HIV virus and activate it. And what we found was that both of these HIV-specific approaches could potently activate HIV transcription. And this is what we found with TAT. I'm showing you non-treated cells, ex vivo, a negative control M-cherry mRNA in a lipid nanoparticle, the TAT mRNA in a lipid nanoparticle, or activating the T cell. And you can see that the potency of TAT mRNA was about higher than full activation of the T cell, and is about 100-fold higher than any prior latency reversing agent. We're currently now looking at this in animal models and hope to get this to phase 1 studies in the next 3 to 5 years. In the last few minutes, I'll just briefly touch on gene therapy, another exciting area of cure interventions. We can use gene therapy to tackle HIV cure in a number of ways. We can use it to protect cells from becoming infected, and this is by engineering uninfected cells to be resistant to HIV, knocking out CCR5. We can use gene therapy to attack the virus, in other words, to enhance anti-HIV immune responses. And we can use gene therapy to purge or get rid of the virus by targeting the virus itself. The main challenge with gene therapy is the delivery. Ex vivo means you take blood out to edit those cells and put the cells back in, very complicated. But now there's advances for in vivo gene therapy where you can directly inject gene editing in the body. So the initial studies of gene therapy used ex vivo gene therapy. This was for CCR5 modification. Cells were taken out from a person with HIV on antiretroviral therapy, modified and then reinfused. This was safe. It was effective. You could alter about 6% of circulating cells to be CCR5 negative, but not enough to prevent viral rebound. In vivo gene therapy is now being used to attack the virus. And here a delivery vehicle, either a lipid nanoparticle or a virus such as adeno-associated virus, AAV, can be engineered to deliver an antibody. So you insert the gene for that antibody in a person with HIV to make them make their own new broadly neutralising antibodies. And this has been successfully done in 2 phase 1 trials, one delivering the antibody PG9 and the other delivering VRC07. The biggest challenge with this in adults is that you do develop anti-drug antibodies, meaning that you can develop an antibody response to the broadly neutralising antibody that you are now generating. But in infants, we see a very different result. So this is studies only yet done in macaques, and this was done in HIV-infected macaques who were given gene therapy to deliver 2 antibodies. These infant macaques were infected with HIV, started on antiretroviral therapy, and then received a single intramuscular injection of these 2 vectors, and then antiretroviral therapy was stopped. And in the 10 macaques that received these 2 vectors, you can see the concentrations of the 2 antibodies in green and yellow. And you can see most of the 10 infant macaques had prolonged expression of these antibodies. So the infant macaques don't develop these anti-drug antibodies because they've got a different immune system. 2 of the infants did lose expression of one of the antibodies. And when antiretroviral therapy was stopped, 7 of these 10 participants did not rebound. So these are really exciting next generation approaches to engineer an individual to produce their own broadly neutralising antibodies. Finally, in vivo gene therapy has been done targeting HIV itself using CRISPR-Cas9. It's first done in SIV-infected macaques, delivering a guide RNA to recognise the HIV DNA and edit it. And the first clinical trial was recently reported of 6 participants. It was safe, but viral rebound still occurred. And further work is being done to generate higher doses and using different delivery vectors. So in summary, I've shown you HIV eradication is possible following stem cell therapy. HIV remission is possible, or what we call ART-free viral control, following no intervention in rare individuals, a short period of ART in 1 to 6% of individuals, but overall these cases are rare, but they provide very important insights for HIV cure interventions. Post-interventional control with immunotherapy has now been observed in multiple clinical trials. These clinical trials are still all small. Some have been randomised. We still need less toxic, simpler interventions and larger trials. There are significant advances to reveal and reduce the reservoir using HIV-specific latency reversing agents delivered by mRNA. In vivo delivery will be the next challenge. And I think we're now seeing, or I hope I've shown you that we've seen multiple clinical trials now of immunotherapy and gene therapy. Both show some promise after many years of negative HIV cure clinical trials. And there are many other innovations in other fields that I think, particularly in gene therapy, are going to continue to accelerate our efforts in HIV cure. I just want to end by acknowledging the many collaborators of different studies I've presented. The names highlighted in grey are members of my laboratory who developed these mRNA latency reversing agents. The names highlighted in pink are members of my laboratory who've been involved in our immunotherapy studies of anti-PD-1 and antibodies, and like to acknowledge our funders, particularly the Australian government, the US, NIH and AMFA. Thanks very much.